For our next session, we have two leaders, two of my favorite people in healthcare, I'll say it, that are going to share some good steps for improving hospital prices. Start over here, Lee Lewis. Lee Lewis is Chief Strategy Officer at the Health Transformation Alliance, where he helps some of the nation's largest employers redesign how they purchase healthcare. Lee brings a national perspective on what's working and how those lessons translate across different markets. And joining Lee is...
You forgot my name already.
I think it's pronounced Cora Opsahl, my boss.
This is really good. Looking good for you.
Director of the 32BJ Health Fund, who many of you know. Cora will share our playbook framework, followed by Lee talking about HTA. And then we'll do some Q&A. This will be open Q&A, and I know they want to hear from you. So start thinking about what are the pain points that you face? What would you like to pick their brains about? We only have a little bit of time left. Time is fleeting, so please take a moment to think. All right.
All right. Good afternoon. So as Keenan said, Lee and I are going to talk as little as possible, talk at you as little as possible, and then we're going to bring the lights up and we're going to open it up for questions. On days like this, at the end, everybody's tired, you've got a lot of stuff in your brain, and so the last thing you want to hear is us chatting at you for 45 minutes, so we'd rather chat with you. But before we do that, we want to just kind of walk through a little bit of where we've done. So the 32BJ Health Fund is, we cover over 200,000 lives up and down the eastern seaboard. But I want to say, before I talk about the work that we do, I want to say a special thank you to the entire 32BJ Health Fund. I have 75 folks who work for me, and every single one of them are in this audience today. And yes, they all deserve a round of applause.
That's right.
And I want to call them out specifically because I've got folks here who are our health advocates who take phone calls from members every single day to help answer their questions. I've got our data engineering team who make sure we get all of our data in-house in a way that is usable. I've got an analytics team that makes sure that we get to do all of the geeky data nerdy things that we love to do. And I have an entire operations team that makes sure it works every day. We can't come and try to transform healthcare without the work of this entire team. So I just want to say thank you to you all. All right. Now I will tell you a little bit about what we do. So we were talking a lot, you've heard a lot about other things, and so it's like, all right, well, what can you do? How do we actually work through this? And so we've got the new playbook. And I've broken it down into 3 plays. So the first play is we want to encourage you all to go direct. We talked about direct contracting, which, so there's a bunch of ways you can go direct. The first thing I will always say is go directly to your contract. If you have not read your contract, that's the first thing you should do. Every contract. If you are a vendor and you give your contract to an employer, they better understand every single word, and it better be in their interest. I am pro-employer and their contracts. Because contracting is hard, and I am not a lawyer, so the lawyers in the room just make it clear I'm not a lawyer. But one of the things we know is that when you own the contracts, it's your rates. We all talk about rates, hospital prices, but it's the rights. It's how do we manage around those expensive prices? How do you have the right to do the things you need to do? How do you have the right to go to direct? So we actually have a free administrator ASO template available for any employer who wants it on our website. And shortly, hopefully sooner rather than later, we will also have a PBM contract. And we want to share it with all of you because we know that when we all start talking the same language, we have a better chance of actually making change and having some new plays in our playbook. The other piece about going direct is that it's direct contracting. We heard it this morning from Mark talking about hospitals. You'll hear it in a little bit from Lee. It is the work, and I want to be clear, we talk about direct contracting and it can feel huge, but direct contracting can be as simple as one provider. Maybe you're going to direct contract with physical therapy or with labs or behavioral health. We don't need to boil the ocean, but one contract first, right? It's like that domino kind of world, is that one leads to the next. All right, so that's play 1. Play 2 is advocate for policy. I have a good friend in the audience who we have a conversation on a regular basis about why do employers need to be involved in policy? And part of the answer is because your benefit design will only get you so far. You want to know why? Because we'll go back to the first point, contracts. Because your contracts and the contracts between hospitals and your carriers limit your ability to make benefit design choices. You may feel like it's hard. And so at some point there is a requirement for employers, and I will say it, actually everyone in this room, to get involved in policy. You can do it through writing commitment letters. There are a ton of comment periods. Make your voice heard. Come, join us in, join your fellow employers when they go to DC, when they go to Albany or capitals in your state. Policymakers are desperate to hear from employers. And I think sometimes people are like, well, but I'm not in government relations, I don't want to mess with that. Just tell your story. If you tell your story, politicians and policymakers understand what they're trying to connect all of the dots to it. I think the last piece is if you don't have to do that alone. You can join employer coalitions. It's part of the reason why we got Lee here, one of our employer coalitions. Join employer coalitions so you don't have to do it alone. The last play I want to talk about is litigation. It would be great if we could just do this because it's the right thing. But healthcare is hard. And sometimes when you can't do it in benefit design and you can't do it in policy, the remaining choice is litigation, unfortunately. Or fortunately, I guess, depending on,
I'm glad we've got that opportunity.
Yeah, there you go. And so one of the things about litigation is we would challenge all of you, document the anti-competitive contracting practices that you find. Support the class action lawsuits that are out there. This is a way that we get to be, again, part of that larger group, so you don't have to do it alone. And the last piece I'm going to talk about litigation is be aware and pay attention. There is things happening here in New York. Some of you may have heard about the DOJ investigation of one of the hospitals here. But there are also things happening at a national level. And these types of litigations do have an impact to the way that benefits are designed and the ways you're going to have to administer your benefit. And I think on the other side is we really hope this litigation is going to open up the opportunity for us to do more on the going direct and advocating for policy. All right, so Lee and I promised we were going to keep this pretty short and sweet. So that was my piece. These are really the three plays. But part of the reason I brought my friend Lee here is that it's not just going it alone. And Lee's going to talk a little bit about how we do it together.
Yeah, so imagine you're sitting down tonight and you're going to watch something on Netflix. You've got 42 minutes and you want it to be good. So you then begin the doom scroll, as I've come to love it, where half the time the show I end up watching is just trying to choose which one I'm going to watch. But imagine instead that you had a friend next to you who you know and trust and love who has seen every single show on Netflix. And you can just turn to the person and say, okay, just cut to the chase. What should I watch? What's the good stuff? Now imagine, though, that you are running a health plan, and instead of sitting down to watch a show, you're sitting down to evaluate all the strategies that are available to you. And you've only got time to maybe tackle one or two of them in a given year, right? So are you going to go after primary care or cancer? Are you going to try musculoskeletal diseases or heart disease? Are you going to work on your carrier or PBM, or are you going to tackle surgical centers of excellence? And it's hard to know which of these is going to help the most people. Which of these is going to save you the most money? Which actually works and what's just vaporware? And I can't help with the television shows, but what the HTA does is we sit down and we see what the most innovative employers in the world are doing to advance the mission. And we take good notes and we see what works and we see what doesn't. And then with that information, we bring that back to our members and we bring people together. So I have seen amazing things. Let me share a couple examples. One of the things that we do that is my favorite is every month we bring all of these innovative employers together, not in person, usually it's just virtual. Sometimes in person, that's right. And everybody has a chance to share. And it's like, if you want to learn everything you want to know about direct contracting with pharmacies, talk to Jason over at Caterpillar. If you want to know unbelievably how to control costs and fiduciary issues and payment integrity in your claims, Andy, Dan, Scott over at Prudential. If you want to learn amazing things about how to give amazing women's health benefits, talk to Lori over at Organon. As we come together, everybody's able to share great strategies one with another. And that allows us to be able to learn and grow together. And then we find some problems that nobody's got an answer to. And when we tackle those, it gives us a chance to bring that collective action together. An example. A couple of years ago, one of our employers, Ernst & Young, said, hey, we want to offer value-based care to all our members. We have great benefits. We have some of the best benefits in the world. And we want to make sure that no matter what city or town you're in, you'll be able to go even to a value-based direct primary care doctor, and we'll be able to cover it through the plan. You don't have to pay cash. And the problem is we've got 2,000 cities that we need to do this in. That's a pretty tough challenge. There isn't an answer to that. And so we started working, and it took a few years, but we found this unbelievable model that allows us to do opt-in contracting, where we can work with a value-based provider. They can send their claims to a billing entity, a billing service that converts it into medical claims, and it allows our big insurance carriers to be able to pay primary care doctor. And now we've got 400,000 lives of people all across the country, across 7 employers, who can access direct primary care that normally isn't covered at all by anything. And we made it available by opt-in, so that you don't have to go and actually sign 200 separate contracts, but you can simply opt into the program and allow it to run through your regular claims. And we're using that as an analogy of, hey, wait a minute, if we can do this at a primary care doc, could we also do it at an imaging center or an ambulatory surgical center? And then even a big capital H hospital, could we do a contract that way and make it opt-in available for any employer to be able to use if they want, and make it interoperable any to any employer to any hospital to any insurance company to be able to pay the claims. The second thing that we're looking at, also looking at that direct purchasing, is GLP-1s. Anybody else here? Who's running a health plan right now? Just out of curiosity, show of hands. We've got a few of you out here. Okay, outstanding. So GLP-1s are a huge deal right now. A lot of employers aren't even covering the GLP-1s. And so we're looking at, hey, how can we purchase these directly? And that was a big problem. Nobody knew how to do it. Like, we know that there are places you can go. I mean, it's what, every third, fourth ad on Instagram, right, is a GLP-1, someone trying to sell you something. My experience, maybe only. That's okay. No, but they're everywhere. And so they're right there, it's close enough to touch, but working through the PBM and everything is very challenging. So we found a way to be able to convert the claims through so that we can turn them into medical claims. We started with one employer out of Tuscaloosa, Alabama. They're not that big. They're one of the smaller employers in the HTA, about 4,000 lives. And they started saying, okay, we want to be able to save 40%. We want to make weight loss care available to people. We don't want to just opt out of it completely. And so they started buying it direct. They then shared that with the rest of our employers, and now we have 2 others who are following, and in Q1 we'll have 3 employers with 30,000 lives who are all going to be buying GLP-1s direct and running the claims through the medical. And those are a few examples among dozens and dozens more of ways that we're working together as employers to find and create strategies to actually advance the mission.
All right. And so that is really all that Lee and I have as our prepared remarks. So I now actually would like to bring the lights up, because now we actually want to hear from you all. This can be questions you have. It doesn't have to be about us and the things that we've talked about. I mean, we like talking about ourselves, but it doesn't have to be. It can be about anything you've heard today. And so if you have a question, go ahead and stand up. As people are thinking and trying to formulate something really fun and exciting. Keenan, I think you've got at least one question as we look to find other questions. And as you stand up, wave your hand so I can point out to the microphone people. And please don't let me down and make this like awkwardly quiet.
Yeah.
Keenan,
Hey,
you got
Lee,
a question?
Cora.
As we have one, I think then
We
you'll
have
be
one
the
right
next
now. We
person.
can start here.
Great.
Keenan, you can go first.
All right, Sean, me first. All right, imagine you're a newer benefit manager. You see all of these problems. Where do you even start? What's the starting place for some of these benefit managers that you would advise?
So I would say, I used to say, so the question is like, where do you start? Where do you go first? I used to always say, get your data. I've now edited my answer, and my first answer will always be read your contracts. Because the reality is, under the Consolidated Appropriation Act, you should all be getting your data. Most employers are getting their data nowadays, or mostly sort of hoping and pleading for their data nowadays. But read your contract first. Your contract is going to be your ammunition to go back and get the data. It's also going to help you understand what opportunities you have. Lee?
It's great. What I would add on top of that is, making the request around having it and making sure that you have some place for your data to go so that you can look at it.
Yeah, now it's your turn, Sean.
If I can get my mic on. Here we go.
Here we go.
Good to see you both. Thank you, Cora and 32BJ, for putting this together. So, something like a question about hospital efficiency. Hello?
There you go.
Hospitals don't compete on price, right? They compete on everything but price. And we know that efficient hospitals can actually break even.
Clearly, some folks don't want to hear this question from Sean.
Oh, well,
So
you're
we're going
right.
to try a different microphone.
Well
And
played.
if you have a question, go ahead and stand up, and we will point to you next.
How's this?
All right, that's
All right,
it.
let's
There
try
you go. Let's hear your question for real this time, Sean.
For real this time. Okay, so hospitals don't compete on price. Efficient hospitals can actually break even on Medicare. We know that because we can see it in the data. And yet there are very high price hospitals that continue to run very narrow margins, right? 4, 5, 6%. Ultimately, I think it comes down to some hospitals are just really damn inefficient, and there's no reason for them to make 25% profits, because that's actually bad if you're a tax-exempt institution. Is there a role for employers on focusing on that issue, or should we just be focused on price and just saying, like, I don't care whether you're efficient or not. There's a certain price that we're willing to pay. There are prices that are above that we don't want to pay. What's the role of the purchaser community in that debate?
So I'm going to circle us back to the very beginning when Claire talked about the impact of price. And over the past 5 years, prices have gone up over 100%. So while I think efficiency is important, especially as we think through, when you start to have direct conversations with direct contracting, the reality is price is what's impacting it. Price is the bottom line. It's the bills we are all paying. So my perspective is efficiency matters. And when you are looking at direct contracts, we should look at hospitals that hopefully are a little more efficient. But in the end, we need to be talking about price. Price, because it is, frankly, what's coming out of our pockets. That'd be my opinion. Lee?
Yeah, I feel like if there's never any reason to get better, we can't expect them to ever improve. Like I have kids, and if I never ask my son to clean his room, guess what state the room's going to be in? Like, we all know the answer to this. There's no mystery here. If hospitals never have to manage their costs, if there's zero pressure ever to run their operation like a business, to use, Mark mentioned it earlier, cost-based accounting, then it'll always be a mystery. They'll just be poorly run businesses. And I think there's a compact there that we are agreeing as purchasers, as customers, to bring, to rely on you to take care of us and the community and the population. And the reciprocal understanding should be that you're not going to spend money like drunken sailors. I'm not saying that all hospitals do that, but some of them, I'll have people who've even been working inside the hospital will admit that, we spend on stupid stuff all the time because there's no pressure for us to improve. And so I think as we, not immediately or overnight, but as we get better at steering to value and doing our best to reward those who are managing their business and minding their shop, then you do like my friend Andy Gregg likes to always say, Lee, you either change people or you change people. And we need to either change the hospitals that are being run poorly, they need to get their house in order and lower their costs, or they need to come under new management.
And then I think, Lee, what you're kind of saying also goes back to what are the new playbook. The new playbook is that we actually have to do things differently. It's kind of like you don't change unless you change, like, right? Exactly what you're saying. So it is this element of, we do need to purchase differently. We need, we're going to continue to reference your good friend Andy, who happens to be in the audience today. It's like Prudential knows how to look at claims better than almost anyone I've ever met. And they are just doing it in a very specific and unique way, which means they're doing it differently. And I think it's a lot of we have to think about how do we do things differently. All right. You all, no one is standing, which means you're going to make us, all right, there we go. Question right there. It's like you're going to make Lee and I start to do some sort of tap dance thing, and that's going to be awkward, and I will trip.
We'll just call on people. No, this is good.
Ooh, that could be fun. Because we know most of you here now, so.
Thank you. Hospital contracting seems impossible from an employer perspective.
Yes.
Where could employers begin to even start? Sounds great. What's the first step?
Oh, I don't know how to answer this in a non-snarky way.
We love snark.
I mean, I think the answer is, where do we start? I don't know, hospitals in this room. Does any of you want to partner with the employers? Because I think one of the things is that, and I have had this conversation with other people, it's like employers want to do this. And you're right, it is hard, and I'm not going to pretend that it's not hard. And part of the reason it's hard is because we can't actually see and have zero transparency into the current contracts, so we don't always know what we're getting ourselves into. But one of the challenges is, I think it's finding the partners who want to do this. So I'd say the first step is find the partners. Whether it, again, I think start small. It could be if all of your employees are in a specific area, such as like our good friends in Alabama, find that providers that you know are high quality, right? So I would say start small, but
what
also
pricing terms?
We need to find, and pricing terms, oh, you want to talk about price, okay.
Yeah.
Again, I've got to try to figure out how to dial back the snark just a little, even at the end of the day. We have transparency, in theory. I don't know, how do we talk about price, Lee? We got to talk about it.
Here's my thought on this. A couple of principles. Principle one is the most expensive price you will ever pay is the one you cannot see.
There you go. See, he's not snarky. This is why we,
It depends on the scenario. The second principle is, okay, so if we firmly anchor ourselves in the fact that if you can't see the price and you can't see the terms, that is the worst deal you can ever have. And so let's call that what it is. That's awful, okay? That's awful. And that's what we do for 99% of what we do, is we have the awful deal. So now we've reframed. The problem I have is, and I see this with my large employers all the time, is they're like, oh my gosh, Lee, if we're gonna do a direct contract, we have to choose our hospital, and then we have to get to know them over a few, 6 months. It's like this long cotillion dating process before you sort of consummate a relationship years later. And the reality is that is a really long, drawn out, hard process. And they end up with one contract, and there's upside downside risk, and there's all these expectations, and then there's an actuarial team that has to manage it, and then you have to hire a new administrator just to pay the contract. I call it like an arts and crafts contract, because you've got all kinds of weird stuff that everyone threw in there because it was built by a committee. And I would submit that's not the way we should do direct contracting. We need to say, look, where we are is awful. Let's try to be slightly better than awful. Okay, what does that look like? It looks like a non-committal, simple agreement that is transparent. Remember, the worst price is the one you cannot see. So you just need a price that you can see with no other strings attached, and that's way better. It could be 1.5 Medicare, 2 times Medicare. It could be 2 1/4 of Medicare, but no outliers. Or it could just be fixed prices on a menu. Have them create a big menu like at a restaurant that just shows all the stuff they have and what the price is. no matter what is written there, it's better than what you're paying. And once that's the baseline that you're going for, keep it simple, and then you can download that. If it's simple enough, you can put it in with almost any carrier. And that's what we're looking for right now, is how do we make slightly less awful contracts really easy and available to anybody? And then you can make them better if you want.
All right, I think our goal should be maybe better than slightly less awful, but I agree. I think the other answer I would have
I like
in a
low
more,
expectations.
in a more practical answer is prices are available. They are hard to find. I always like machine readable files are not meant for people to read, but they are out there. And there are excellent vendors out there who will help you translate it. You should, again, it's get your data. Even if you can't see what's out there, if you have your data and you have your claims data, you know how much you paid for a colonoscopy. So when you get to go in and you say, again, back to the menu, you at least know where you're starting. So and every deal is going to be different. And you're going to have to decide what you care more about, what you care less about, and how does that navigate within the hospital system. But you at least, as soon as you start with your claims data, you have at least your beginning master price list, and then you can go from there. And your claims data is receipt for payment. It belongs to you, full stop. Don't let anyone tell you otherwise. So I would start there. All right. Next up, do we have a question back here?
Hello, Cora and Lee. Cora, thanks for your team and the great work you've done today. I have a question regarding group purchasing. And the one thing I didn't see today, we talked a lot about legislation, but I came from the hospital industry where I worked for a group purchasing organization, and that brought all these hospitals together, and they bought through one contract as a group, and they then were able to amass their volume. It would strike me that employers could stand the benefit for doing the same thing. In other words, everybody else is concentrated except for employers. And I haven't seen a lot of actions where employers get together and say, we are only buying through this agreement that we are going to back with all of our volume in a city, or a PBM, or a point solution. And I'm wondering, and Lee, this would be a good question for you, what efforts are underway to do that? And I was curious also, Cuban seemed to be doing some of that today with his do a contract, make it available, but you can buy through it as a group, and that starts to be that bud of a group contract.
Yeah, you go first.
All right, so I will go first. I think that group purchasing works first. I think when we think about group purchasing, we often think like we all come together, we buy the same thing, but that it becomes a one-size-fits-all. And I think one of the challenges is that group purchasing for employers is not always one-size-fits-all. I have an amazing benefit I get to adjudicate that has no premium sharing and no deductible, and we have low copays. Meanwhile, group over here might have a very different benefit structure. So, but I will say what I think that we can start to do, it is the work that we are doing right now. It is we all ask for the same contract terms. That I also think employers need to start talking about the wins that we have that violate no confidentiality agreements, right? Like, I will tell you, I'm going to get claim line level rebates in my PBM contract. So anyone who says, oh, they won't let me, well, they let me. So why do I get it but you don't because I'm 200,000 live? Well, you get to start saying, that's interesting. So we need to start talking about the wins that you're allowed to say. And I would, and that we need to start having these conversations out in the open. Too much of contracting and healthcare purchasing is done in the dark. And it's done between, employers are not being engaged at the table, and too much of it is done through, here's this 60-page contract, sign on the dotted line, and hope for the best. So, I think that that's my answer, is that I totally appreciate it. I also understand there's a bunch of laws related to some of that stuff, but not a lawyer. But I think there's ways to do that without having to bring everybody together to purchase the same thing. We can just start purchasing the same way.
Yeah, to layer on top of that, especially because within our organization we're working with Fortune 200 employers, and to try and get multiple of them to buy or do any one thing at the same time in the same way is not possible. Like, it's not reasonable. And so we have to find ways to work together as a group, even though every single one of our employers is a sovereign entity and is going to have many different customized things. And so how do we do that? The first is we try to find strategies that can work with just a single employer who wants to take action. Because if I can get one person to do something, I can get 2 more to follow when it works. And if I've got the 3, I can lever that to 6 or 8 very quickly. And that becomes sort of a diffusion of innovation curve, where you have your sort of innovators and then early kind of, early majority, or your kind of then later majority, et cetera, to where more people can accept something. So that's one way that we can do it, where after a few years, I can get a lot of employers to take a similar action. I just maybe can't do it all at the same time. The second thing that we've looked at is the power of opt-in contracting is like my favorite thing. It's like enriched uranium that we just discovered. It's like, this stuff is powerful. Where if we can get a contract with an entity that says, look, anybody who's opting into this can be a third-party beneficiary of what we've just signed, then I can take an employer who takes 3 years to sign a contract, and I can have them at it in a couple of weeks. Because they don't have to go and sign a new contract. They can just raise their hand and say, sure, I opt into that. And it's non-committal. It keeps them protected. There's no gotchas in there that they have to worry about. They can opt out just as easily if they want to. And it gives them that full flexibility while still having pretty concrete terms that have been established between the contracting entity and whoever else we're buying from. And that's something that we're exploring in a number of areas to try and make rapid, scalable adoption a possibility, where I would have said last year it's impossible.
So every year we get a little better. Yeah. All right. Next question. Back in the back. Microphone's coming to you.
I'll start.
All right.
The microphone gets here because I can do that.
Yeah.
So the first part
Oh, it's right behind you.
in the previous panel, the woman that was sitting on the left made a comment that really resonated with me in a new way of kind of defining the way to work with hospitals. I've never heard it before, the analysis, but her comment was about employees that are on a performance review program because of non-performance. It's almost like you guys are talking about meeting with your hospitals and saying, we're putting you on a performance program. Here's where you're not measuring up. And I think there's a lot of authority that is implied authority that employers have that they don't exercise because they don't ever think they can actually talk to a hospital. But I loved her idea, and I just thought it was great. My one question is about navigation. I've heard a lot of conversation about direct contracting, but what do you believe about navigation? And then the last part was really more on the legislative side or the external side, where the chambers of government intersect with the chambers of commerce, who are talking about healthcare jobs and the payroll and the taxes that the people that make a lot of money pay and what it does for communities. The good news that comes from that politicians also resonate with, also has the downside that we're all paying for. So I would love to hear your thoughts on those two things.
I'll let you take care of navigation. I will answer the first one, which I think the first question essentially was, how do we kind of how do we get employers to go to the table? How do we get hospitals to go to the table? And one of the ways I would say it's through organizations like the Health Transformation Alliance, it's through organizations of other, trade associations. It is also having more employers standing on the stage and saying, I want to talk. And so I think part of it is, it's like we are trying to give the voice to people who don't always know that. So I think there's a piece of that, and I guess we can go I'm putting you on a performance improvement plan. I'd rather go, who wants to be my partner? Because I think maybe bees with honey, clearly. It's been a long day. I think we can go more bees with honey. So that's kind of my perspective on that one. Care navigation, Lee.
So I think the last job of any benefits team, that once you've succeeded at everything else, once you've fixed for the centers of excellence, all your clinical programs are in place, you've got your carrier and PBM managed, tight, fixed, once everything has been done, the final job that any of us have is effectively a marketing job, which is getting people to the right place at the right time, getting the right therapy at the right price, and bringing that all together, which gets at navigation. So we're never going to be too good at this, and it's long term, it's the most powerful thing we can learn how to do, is being able to get people into the correct areas. If we could take all of the spend that we have just in this room, in our different cities and towns, and could ensure that everyone is just going to the upper quartile. It doesn't have to be the best. It's not a beauty pageant. It's just upper quartile docs who are doing a good job on value, and receive those services in the upper quartile of buildings, facilities, that are not completely hosing us on prices. If we could do those things, I think in 6 months we would have realigned the incentives, and in those cities and towns, you'll hit a tipping point, and the hospitals will be forced to reckon with this question. How do we lower our prices and improve our outcomes so we can bring back the patients we've lost? If we can plant that question into the minds of hospital administrators, that will change behavior. That will help us to start turning things around. In order to succeed at that, lots of things that we can try. We can try with navigation and customer service through our administrators. We can try through mobile apps that try to interface and find people, or that use different modalities or claims data to be able to find people who might need one solution or another. And then finally, we're betting a lot on primary care. We know that primary care doctors issue the referrals, so they appear to have a lot of control. Certainly the hospitals all believe that. And so if instead we can partner with primary care rather than having them all be acquired by insurance carriers and big hospital systems, maybe we've got a shot at getting control over our wallets.
That was an excellent answer.
Oh, thanks.
Yeah. And then I think the last question on legislation and is that what I would say is, there's a lot of pieces and comes to legislation, but the biggest piece for me is on the employer side, is that, and someone said something, and she said it much better last night at dinner, but I'm going to butcher it, was that if you're not in the room helping make the decision, then someone's making the decision for you. And I think I would just, so we have time for one more question, and I think there's one right there, correct? And Lee and I will try to answer it in a few minutes, and then I will close us out.
Yeah, thanks, Cora and Lee. Just a plug for the podcasts that have been on Relentless Health Value. Excellent explanation of what you do. I'm a doctor at Elmhurst Hospital in Queens. Our hospital collapsed during the pandemic. As some of you know, we had 200 patients on ventilators. One of the things I haven't heard as much about today is the quality and safety and access question. We heard there's a polycrisis of prices, quality, and access. And there's been 4 hospitals that have closed in Queens over 20 years, which has led to that sort of under capacity in the New York City health system, particularly in Queens. We haven't heard anyone talk about decoupling employment from paying for health care. So I haven't heard anyone today mention the New York Health Act, which a 2018 RAND Corporation study showed that that would save $2,800 for each New Yorker. And I'm surprised that a labor union isn't at least presenting this as a policy issue, as a potential solution to the cost, quality, and access crisis. So I'd like to hear what you think about the New York Health Act and single payer as a potential solution to
well, I think I'm going to not answer the question the way you want me to answer it, which is, I'm not the union, I'm the health fund, and my job is providing employer-sponsored coverage. And so for me, and the reason that we are here is because of the impact of prices on employer-sponsored coverage. And there is a lot of different ways to address it. And I don't ever presume to speak for the union. I make very clear that I don't ever do that. But one of the things that we look at is we do look at a lot of different things, but right now, I am responsible for providing comprehensive coverage to over 200,000 working New Yorkers and East Coasters. And for me, I want to make sure that I am a good steward of the benefit and a strong fiduciary to the dollars that we have to do so. And so I think there's a lot of ways, but the focus of this is really on the impact of prices to commercial insurance and to commercial payers. And so like I said, I don't think I'm going to answer the way that you want me to answer, but I am going to answer it in the way that how it impacts me today. And I think, but it does bring to light that there are a lot of different ways, and it actually allows me to kind of close this out in a really, it wasn't actually 1-2 punch on that one, is that there are a lot of different ways to address healthcare. We can talk about it, we've talked a little bit on, there's about going to direct, and however you choose to go direct. There's clearly a lot of different policy ways to talk about healthcare and affordability. We know there's litigation. And Lee and I kind of talked about these as 3 separate buckets. But I think the really important part here, and the thing I want to leave you all with, is that the way we make change is bringing all 3 of them together, right? We talk about ways that employers can improve their benefits. We talk about how we can leverage policy to do so. And we know that there's litigation that can help us then do these 3 things, but we truly cannot do systemic change without the collective action of all of us in this room. Today, we've got providers, we've got carriers, we've got vendors, we've got employers, we've got like-minded fellow travelers on this road of healthcare transformation. We have my son. I told him I was going to call him out.
Yeah.
Like, we have, the next generation, speaking of my kid, like the next generation of people who want to help fix healthcare. And I think fundamentally that is the piece that we need to think about here, is that as we look to tackle prices, which is what we're focused on today, it does take all of this coming together for collective action.